Hello, everyone. Hope you guys are doing well. Hope you had a good spring break and managed to do some things that were fun and away from school. Um, just a quick note on the tape distribution. I'm planning to go ahead with that in the second week back after spring break. So not this week, but the following week. That way I can get everything together and organized, and it works better with my schedule as well. Okay, so today we're talking about injuries to tissues, specifically muscles. So let's get going. As always, feel free to pause if I'm going too fast. I will go faster than I do in class, just how it is. Okay, so just quick look at what the muscular system is. I don't want to spend too much time on this. This should be review for most of you. We have 600 muscles within our body that helps us move in a variety of different ways. And each of those muscles are made up of tiny bundles of contractible tissue. That means that the muscles slide past each other, they contract and pull in closer, slide past, relax, pull apart. That allows the muscle to change in thickness and length, moving joints around and causing movement. Okay, the stimulation of that contraction is caused by nerve cells. Skeletal muscles are voluntary. It's controlled by our thoughts in the brain. Our thoughts tell us when we want to move our arm, we send a message from our head. That nerve signal causes stimulation of the muscle, causes contraction, and thus movement. Okay. Later this week, you guys are going to be producing a document of these different types of movements. Now, the assignment actually should be out there because I'm going to post it all on Monday. There are multiple ways to do it. You can either do a video, which means you can kind of knock it out really quickly, just transition from one to the other. You can do photos, or you can do drawing if you don't want to put yourself on video. So there's options for you to do that. But through all of these types of muscular movements, you need to be able to demo what they are. Okay, so the first one is rotation. Hopefully that's pretty obvious. I will demo some of them now, but I'm not going to demo all of them because I don't want to put my feet on camera right now. So rotation, that's turning around an axis. Okay, so the axis is my spine, and we have rotation around that. So have rotation around the arm, where the humerus through into the radius and ulna is the axis, and we've got a rotation around it. We have abduction, which is going away from the body, to abduct, to take something away, and then to adduct, to add, bringing it back down to the body. Flexion is the closing of a joint and a decrease of the angle between two bones. So if we look at this joint, the angle between these two bones is 180 degrees. Flexion is closing. Now the angle is 90. We're moving those two bones closer together. So that's flexion. Extension is the opposite, the opening of a joint going from 90 to 100 degrees. We see an increase in the angle between the two bones. Obviously, the joint places some limits on that, right? So I can't extend beyond 180 degrees because of my elbow joint. It doesn't allow that movement. Okay. This is the one I'm not going to demo. Dorsiflexion would be bringing your toes towards your knees. So we have the flexion, the closing between the tibia and the metatarsals. That angle is closing as you bring your toes up. And then this is also called flexion, plantar flexion, because it's flexion on the opposite side of the joint because we're changing the angle between the back of the leg and the foot as well. So that's called plantar flexion. That would be pointing your toes away from the body, kind of like ballerina toes. The next two, pronation and supination, these can happen in multiple places in the body. We can have pronation and supination around the shoulder. We can have it around the ankle joint. You may have heard of that. People pronate when they run, like it's a typical error with runners where you see the foot adjusting and turning through as it touches the ground. But the easiest way to demo it is with the arm. Okay, so pronation would be rolling the palm back, supination, rotating the arm so the palm faces forward. Pronate, supinate. Aversion and inversion, these are looking at the ankle. So when somebody has an ankle sprain, um, depends on whether the ankle goes outwards or falls inwards. So going outwards, we call that an aversive or an aversion um, sprain. That one is more common. It's more common for your ankle to roll to the outside. And then an inversion would be the ankle rolling the other way. And then the last one, that should not be dorsiflexion. I know it is dorsiflexion still. Dorsiflexion of the hand is bringing the back of the hand towards the forearm. Okay, so we have dorsal flexion of the hand, and then we've got palmar flexion here. And again, normally flexion and extension are opposites, but because of the type of joint we have in the wrist, being a condyloid or an ellipsoidal joint, it can flex both ways. Okay, so we have dorsiflexion versus palmar flexion. Okay, skeletal muscle. So we define a muscle's direction by its origin and insertion. So those are the 2 points of attachment. So your muscles are always attached in 2 places. Okay, they have an origin and an insertion. The origin is the end of the muscle where movement does not occur. And insertion is where the movement does occur. So instead of me demoing that, I have a couple of pictures for you. So if we look first at biceps brachii, the origin is at the top because when your bicep contracts, it doesn't change anything around the shoulder. Okay, but when your biceps contract, your hand comes up. So there's movement around the elbow. So that's the point of insertion. See, that arrow is slightly misleading. The point of insertion is going to be down further across the elbow. Okay, otherwise it wouldn't move, right? So we have to have the insertion beyond the joint. So when we get contraction, it causes that movement. Same thing is present in the quadricep. The origin is in the hip. So when you contract your quads, it doesn't cause any movement around the hip. The movement is around the knee. Okay, and then the insertion is, you see the insertion coming beyond the knee. So when we get contraction of this muscle, it's going to pull the foot or the leg into extension. Okay, so that's what the quadricep does. It's an extensor or muscle of the leg. Okay. Right, how skeletal muscles are attached. You probably should know by now that tendons are what attaches muscle to bone. Tendons are strong. They are fibrous in nature. That means they have fibers all running in the same direction. And they anchor the muscle onto the skeletal system so that when we contract, the muscle is pulling at the bone, okay, to cause movement. Okay, the most famous is obviously the Achilles tendon. You should all know that, being at the back of the heel, okay, the Achilles tendon. And it's a good one that you can really feel the strength and fibrous nature of it. Just grab it, you can kind of feel that. Now, not all muscles are attached by tendons. Okay, so certainly if you look at all of the limb muscles, they are, and they have obvious tendons. But some of our other muscles are attached. Their points of origin are an attachment over a much broader real estate, over a broader piece. So some of those are attached by fascia. Now, fascia it does a few things. So fascia is a membrane that goes around the muscles and it helps attach muscles within muscle groups. So like the quadriceps is made up of multiple muscles. Okay, so they're held together with fascia. But fascia also attaches muscle to bone as well. I'll give you an example of one of those here. Okay, so this white area at the base of the lower back, this isn't muscle. Okay, so it's some call it thoracic or thoracolumbar fascia. This one calls it the thoracolumbar fascia. Now, if you look at the root words here, thorac meaning thoracic, which is the middle part of the back, lumbar being the lower part of the back, that tells us where it's located. Okay, so this attaches the latissimus dorsi into the bottom here, attaches the glutes as well. You know, they insert into that lower fascia area. Okay, still looking at skeletal muscles. Let's look at what muscle tone is. So even at rest, while you are kind of sat down, your muscles have some level of contraction. Okay, they're never completely turned off. Okay, so that partial contraction is called your muscle tone. The more active your muscles are, the more tone they have. If you do not use a muscle very much, it's going to lose tone. And eventually it's going to go through atrophy, which is when a muscle decreases in size. Okay, so that atrophy comes through the loss of tone, through lack of use. Now, if any of you have had a cast over your forearm or leg for a period of time, you may have noticed that when you take the cast off and you compare side to side, the one with the cast on is thinner and smaller, and that's because your muscles have atrophied because you're not using them because the cast is not there. When that cast is on, you don't have that muscle tone maintained, so you get that atrophy. Now, if you do have atrophy over a long period of time, whoops, I'm not quite ready for that. Over a long period of time, it can cause damage to the joint. Okay, that damage holds the joint into a flexed position and it becomes very hard to use. This is called a contracture, and that's what that picture was I just flashed up. So you can see you have these, they've had atrophy in the finger muscles because they haven't been using them, and the hand gets stuck in that contracted claw-like position. Okay, if this gets really bad, you can also see it in legs and limbs. Okay, so you have this leg is stuck in this contracted position because of the atrophy. You can see how there's not much muscle left here. And this happens with, lack of use. And this is something that is unfortunately quite common. You know, as an EMT, did a lot of work transporting people from, nursing convalescent homes, and you would see patients with contractures all the time. We transported lots of patients who looked like this. And at first you think, let me just straighten your legs out, but you can't. You can't physically straighten that leg out. It is stuck in that contracted position. All right, it's enough looking at that. It's not the most pleasant thing. Okay, so we're going to look at some specific injuries of the muscles. We're going to look at muscle strains, myositis, ossificans, and tendonitis. Okay, so a definition of a strain, it's an overstretching, tearing of the muscle or its tissues, like the fascia and the tendons. Okay, so typically strains occur around the point where muscle turns into tendon or where muscle turns into fascia. Normally, when you have a muscle strain, it's not right in the middle of the muscle. It's usually around the weaker points. So points of attachments are generally slightly weaker than the middle of the meat of the muscle. So that's normally where as that muscle's put under tension, it normally fails at the weakest points first, which is around the connections with tendons. Okay. So it's you don't want to confuse this with a sprain, because a sprain is ligament based. Strain is muscle and tendon, and I remember that with the T. It's T for tendon. Okay, so when this happens, and I would imagine a number of you have had these, you're going to get localized pain, so it's going to be uncomfortable right in the area. You're going to get decreased range of motion because the muscle is less, as it's torn, it's less capable. Also, you're going to get some inflammation and swelling, which decreases the range of motion as well. Decrease in function, it's not as strong because those muscles are torn and damaged. They can't contract as strongly. And it's going to be tenderness, so pain to touch as well as just pain from being. Now, we have 3 classifications of strains: first degree, second degree, third degree. I'm not going to read this whole table out for you. I'm just going to point out a few things. Generally speaking, things get worse as you go from 1 to 3. So 3 is the worst. Okay, so pain, increase, damage, increase. But there's a couple of things that go against that. So with a third degree strain, there's going to be a complete tear through the muscle. So there is actually no pain during contraction. So if you tear your bicep, when you contract the bicep, it hurts. But if you completely tear it in a third degree, when you contract it, it's not pulling on anything. So there's often no pain associated with a third degree. So it's been so severe, it's torn in part, that there's nothing to pull against. And again, same thing with stretching. No pain with stretching because it's not attached to anything, so it doesn't hurt to pull it. And then thus we would see an increased range of motion. Okay, the muscle's no longer there attached. It's not going to be limiting our range of motion, so we can see an increased range of motion. Okay, how would we treat muscle strains? Generally speaking, in the immediate treatment, which is what you guys would be called in to do, as an athletic trainer or when you're in sports med 2, is going to be the application of ice. Okay, so what ice does, it can help with pain, it helps with inflammation. So that's why it's applied immediately. Okay, so now this was going to be something we were going to learn and practice. I may get some demos of it, but it's going to be hard for us to practically practice this. So basically, you apply it and then you wrap it. Okay, and you want to wrap it in a certain way to hold it against the body to keep it there. Now, with ice, you don't leave it on indefinitely. It's usually in bursts of 20 to 30 minutes. Take it off and then ice it again. Now, if we do get a third degree sprain, you would treat it the same way. You would apply ice for pain management and decrease inflammation. But obviously, first degree and a secondary sprain usually heal fairly well by themselves with just some rest, gentle mobilization or stretching, and gradually increasing the movement back up to where it was. With a third degree sprain, that's not going to work. It's going to often require surgical reattachment when we get that complete tear. Okay, so our next one, this is one you probably have heard of, called myositis ossificans. Basically what this is, you can see the OC root word, which you may remember is bone, and myo is muscle, and that'll tell you a little bit about what it is, and then the itis of inflammation. So basically what happens here is we get calcium produced within the muscle after a blow or contact, and that has to be pretty severe blow. And ultimately what that can lead to is this hard mass of calcium rich muscle inside of the muscle that becomes immovable, right? It doesn't contract. So you can get these solid pieces of calcium stuck inside the muscle. Pain is the primary symptom, but you have to think about the context. So it has to have happened around that impact. And then it doesn't immediately occur. So this might occur in the days afterwards. And you might feel or palpate a hard mass in the middle of the muscle away from the bone. Okay, so that's what myositis ossificans is. Now, if you have, there's an image you can see in an X-ray some calcification where it shouldn't be. Like we should see no white here because this is the muscle. But you see this deposit of calcium here showing up on the X-ray. And that obviously, hopefully you guys recognize, is the top of the femur. Here we have the pelvis, the ischium. Okay, so immediate treatment is we want to pad around it because it's going to be tender to the touch and painful. So we'll use around the contact point, we'll use what's called a donut pad. Obviously because it's a donut, because there's a hole in the middle. If you don't have these, you can create these. And basically we want to pad around it, but not all the way on top of the pain. Because as you wrap around something that's painful, it's going to hurt. So you have the area of space, but provide some padding around it. After a blow type injury, you do want to keep range of motion. Okay, so we want gentle movement and then that can prevent the ossification or the calcium forming within the muscle. Okay, so sometimes things that they'll do is have low impact exercise, like a stationary bike, because you're sitting there, there's no gravity really working, you're just contracting that muscle to turn the pedals. Okay, our last injury is tendonitis. Now, remember, a tendon attaches muscle to bone, um, but something we haven't really talked about is the tendon is wrapped in a tendon sheath. Okay, so like the sheath of a sword is what you put the sword in. So the sheath of the tendon it wraps around it. Now, tendonitis occurs when you have repeated overuse of a muscle and tendon, causing this inflammation and lots of little tiny tears within the tendon. This occurs in sports with a really highly repetitive action. So you want to think about like a pitcher who's constantly throwing and contracting that muscle at max effort. You often see pitchers with tendonitis around the elbow and shoulder. For me, as a volleyball player back in the day, I had tendonitis in my hands from setting. You'll see volleyball players with tendonitis in the shoulder from hitting. And you can think about whatever your sport is, where the repetitive actions occur. Symptomatically, what shows up is soreness, tenderness, both with movement and without movement. Occasionally, you get swelling, but that's normally not seen very. You don't see big swollen edema. You're just going to have tenderness and soreness with and without movement. Now, how we treat tendonitis, we want to ice to decrease swelling, allow the body to rest, which can be difficult in a sports setting. So often what happens with players with tendonitis is they learn to manage that pain and discomfort through their competitive season and then rest in the off season. And I know that as truth because, I played with tendonitis for years. And then it would get a little bit better during the off season when I could rest it. And then it would flare up again during season and you would just kind of manage it. So ice, rest, and then supports. So you want to use things like a neoprene support. So you might see people with like a shoulder sleeve, or I used to have wrist guards and sleeves, elbow supports. And now there's one thing that isn't in the textbook that I thought I would share with you from my experience. It's something called point friction massage. So what happens is if you have the tendon sliding in between the sheath, you can get scar tissue building up from all these tears. So it becomes less fluid as it contracts and moves through the sheath. So you get this buildup in between the tendon and the sheath of scar tissue. So what treatment I used to use was point friction massage, which is basically applying let me put this down so you can see my hand. So I had it here and would apply like a lot of pressure against the pain area and then roll massage through it. It's called point friction massage. And basically it's trying to break down the scar tissue between the tendon and the sheath to allow it to slide past with less pain. All right, I think that's it for today. I should hopefully have the quiz posted by the time you get to this on Monday. And I hope you guys are well, and I will catch up with you soon.